Good evening from Tempe, Arizona. This is Dr. Stephen Vorholt. I'm excited to be with all of you guys and gals tonight to learn about some surgical stuff, some implant stuff. A little bit about me. First off, tonight we're going to talk about fully guided immediate aesthetic zone implants, which is a mouthful. But essentially, we're going to talk about a couple of things. We're going to talk about how do we approach immediate implants in the anterior maxilla, and then how do we take this new digital knowledge that we're all so fond of and utilize that to help us be even more successful. So just a quick little blurb about me. We have a lot to get through tonight, so I'm going to speed through some of this. But essentially, I graduated from The Ohio State University 8 years ago and had my own practice for 5 years. I've recently moved to Tempe from Ohio to join Implant Pathway and the clinic that they run down here. And as the surgical director, I get to see all the implant patients as they come through, from screenings to surgeries, follow-ups, the inevitable complications, and all the way to their final restorations, which is almost 5,000 implants a year. So if you've heard of it, I've probably seen it, which is part of the reason I took the job, so I can get to learn so much and have my hands bloody, if you will. First off, I have to thank the sponsors of the clinic here at New Horizon. Without these companies, what we do down here at the nonprofit would not be possible. So thank you to everyone. Meisinger, the Burrs, an awesome TAC kit, Sprint Ray for the 3D printers, BioHorizons for the biologics and implants, Chiapi for patient communication, ProSmiles Dental Studio for helping us out getting people teeth, Proceed Finance for helping people afford those teeth, and of course Acteon for our 3D imaging. So tonight's webinar, just a quick overview of kind of what our outline is going to be tonight. We're going to review some immediate aesthetic zone implant rationale and surgical considerations. We're going to talk about the rationale and the limitations of guided surgery, which is something that we probably don't talk about enough. There certainly are some limitations. We're going to talk about the techniques that are a little bit different for immediate guided surgery over maybe a traditional delayed guided surgery in a healed site. And then we are going to take a little bit of time, and I'm going to walk through a live walkthrough using the software that I utilize to make guides and to read our cone beams here at the New Horizon Surgical Center. And then we will go through that same case because the surgery was done several months ago. So we'll get to kind of go through and see how it all went. So first, just a review. For some of you, this might be a review entirely. You're already well versed in this. For others, maybe this is some new information. So when we're talking about apical coronal placement of dental implants in the anterior maxilla and anterior zone, the platform of the implant where the connection is should be roughly 3 to 4 millimeters from the future gingival margin. Typically, that's about 1 to 2 below a healthy buccal plate. So some good metrics to kind of understand. And then Tarnow came out with a study years back that's been vital to understanding aesthetics in this area. And that's that from the peak of bone to the bottom of the papilla cannot be more than 4 to 5 millimeters, or else you're going to likely have one of those black triangles that we all try to avoid. When we're looking at it from the buccal lingual perspective, we want to be a minimum of 1.5 from the buccal plate, ideally a little bit more, especially if we have to flap during our surgeries, because that will reduce a little bit of the blood flow and potentially lead to a little bit of resorption post-surgery. If the gap between your implant body and the buccal plate is more than 2 millimeters, it's recommended that we do graft that gap. Studies are constantly coming out about that as far as how big that gap needs to be. And my kind of thought on it is if you can fit graft material in there, go ahead and graft. It certainly doesn't hurt anything. Ideally, we'll do some flapless surgery so we can avoid the blood supply inhibition in that area. And keep the periosteum on the buccal plate, because typically the buccal plates in this region are very thin and fragile. And there are newer techniques constantly coming out. Some of you may have heard of socket shielding. Not something we're going to talk about tonight, but there are techniques that are coming out to help maintain that buccal plate and some of the contours. Root banking is another example. So things that are constantly evolving, especially in this highly aesthetic zone. When it comes to where we place our implants, the green circle here kind of highlights the main zone of where we're aiming to gain our primary stability. So above apical and palatal to the root socket is the typical zone where we're trying to get primary stability. You could potentially engage the floor of the nose. There's a nice thick cortical plate at the floor of the nose that can give you bicortical stabilization and give you a little extra torque, maybe if you're looking at immediately loading or just want to make sure that the implant's going to be nice and steady. If you can't get primary stability, it's best to graft and come back and not try to put, certainly we're not putting implants that we might call spinners or things that are very, very low insertion torque in this region. Ideally, we're going to be above 35 Newton centimeters of rotational torque. And I'm a big fan of ISQ, which is implant stability quotient. You can get that with the Ostel or the Penguin, are two popular options for that. We'll talk about this a little bit more in depth when we get to the surgical case review, but above 70 is the kind of the accepted region for where we're going to be immediately provisualizing or loading an implant at the front. Anything above 65 to 70 is typically in the healing abutment, custom healing abutment range. So we do want to hold on to as much bone as we can in the apical palatal region so that we can get one of those two options when we're doing this surgery. This is a study that was done by Howie Gluckman, who is actually the kind of the main proponent of the socket shield technique. But he did a study, a retrospective study of 591 teeth in cone beam slices to get an idea of the root and alveolus morphology that we typically see in the anterior maxilla. And essentially, class 1, which is in the top left, is when the tooth root is kind of right in the middle of the two plates at a pretty moderate angle. Probably the most ideal for an immediate placement, whether it's guided or non-guided, because the root socket itself will kind of guide you into the ideal positioning for that apical palatal bone. Class 2, which is, and he splits it between 2A and 2B, whereas 2A is a thicker buccal plate at the crest and 2B is a much thinner buccal plate at the crest. That is the most predominant display that we get when we, and I'm sure if any of you are seeing cone beams on a pretty regular basis, you see this all the time, a little bit of a retroclined anterior maxillary teeth. And so what that leads to is a difficult surgery to find out how we're going to get our osteotomy to be palatal and apical to this root socket, because those sockets will try to kind of force you back into the buccal, because that cribriform plate, which is the denser area right around the PDL and the bone and the tooth, will deflect drills. And that's something that we do have to take into concern when we're talking about class 2 teeth. The class 3, 4, and 5, in this study, he kind of relates that these are probably the more contraindicated for immediate placement, are probably more easy to do a delayed graft and come back. Class 5 is, thank gosh, class 5 is the most rare because it is exceedingly difficult to treat with those apical constrictions above the root socket here. So class 3 could certainly be done, but it's a little bit harder because of the proclination of the teeth. And you'll also see this in a lot of patients who have gross periodontal disease and the teeth have started to flare out. It can be a very difficult thing to get crown and bridge FP1 implants placed there. So as far as the surgical approach, here's this is a patient here that we saw at the New Horizons Surgical Clinic, just grabbed a slice. This is number 10. There's generally 4 options for the angulation of an osteotomy in the anterior maxilla if we're going to extract and immediately place. Option 1, follow the trajectory of the root socket. It's pretty clear. It's probably the easiest to do. The root cribriform plate, like I said, will tend to deflect your drills and kind of help you, if not hurt you, to maintain that trajectory. Number 2, you could bisect the buccolingual alveolus, and that's what we talk about when it's like where the bone is where, you know, we make the joke that the surgeon just puts it in the middle of the bone and then the restorative dentist has to figure it out. That is something that in the anterior maxilla can lead to some certain problems. Option 3 is a more palatal bodily placement for a cement retained crown. So a custom hybrid abutment, cement retained crown, that's going to be coming out the incisal edge of the tooth. And then number 4 is more for screw retained crowns, also a palatal bodily placement, but getting the angle to come out behind the incisal edge. And I make a note here that types 3 and 4 can often be combined in the sense that you could almost bisect the two. And with new restorative options now, like angled tie base or angled screw channels, a lot of times we can actually kind of get the best of both worlds when it comes to 3 and 4. So let's look briefly at some examples of each of these. So example one, if we follow the trajectory of the residual tooth root, which is what a lot of us don't want to do, but can often happen incidentally, almost like an iatrogenic surgical complication, because you will look at the line here at the bottom of where the access is coming out of the tooth, and it's like, this looks good, it's coming out of the cingulum, great, but what we don't realize is the apex of our implant, the apex of our drills has been pushed along the trajectory of the root and often will lead to buccal fenestration at the top. Now, sometimes these can last years and years and years, if not forever, especially if we did not flap at the time of surgery, but it's a complication we'd like to avoid. It can certainly lead to more problems down the road. Option two, which is bisecting the alveolus, here we can see that the access point, or the screw channel, if you will, is coming out the mid-facial of the future tooth. So this wax up tooth that we have in our slice here. So a couple problems with this. For one, it's very difficult to restore this without some sort of angled custom abutment or angled screw channel and an angled custom abutment. But the loads, regardless of what your abutment design is, are going to be at a steeper angle to the implant axis. And we, as most of us probably know, the most implants are the most strong when the loads are directed parallel to the axis of the implant. So we already are fighting with that in the anterior maxilla and giving up a little bit of that, knowing, hey, it's going to be a little off axis. But by doing this kind of preparation, we're actually exacerbating that sometimes. And it can be very difficult and can be a very unaesthetic result as well. Option three, what you can see here is, these are very minor differences. Take a look at the difference in the angle. It's just the apex of the implant, where that is being pushed. This is coming right out of the incisal edge of the future crown, and this would be for a very ideal formed custom abutment. A custom abutment that will have a nice ability to block out any titanium base. It'll have even thickness on the palatal and the buccal, and will be a very simple thing to cement a crown in the front. So it's a little bit less technique sensitive than the one we're going to talk about next, where we're talking about screw retained, because it will require some cement. So anytime we're talking about cement retained implant crowns, there's a higher chance for peri-implantitis. So if I prefer everything to be screw retained if possible, but cement retained in the anterior is certainly a viable option. And sometimes it's the best and only option, because option four, maybe due to an undercut in the anterior maxilla, is not an option. So this is still a very viable option. If you are planning on doing a single, say just number 8 broke, and you're also going to veneer number 9, or maybe crown 7, 9, and 10, sometimes this gives your lab a better chance at getting, a good aesthetic result, because they can do the stump shade on the abutment and kind of make sure that translucencies, whichever porcelain or zirconia you guys are using, can be matched a little bit easier than if we're doing a screw retained crown. Option 4, which is probably the most technique sensitive, and you can see this angle is just slightly more buccal than the last one. It's probably the most technique sensitive approach for freehand placement, but it can give you the most ideal restoration for the longevity, because there's no cement, so less likelihood of peri-implantitis. Is not impossible, but less likely. It's retrievable, so if there's ever, everything's retrievable, but this is certainly much easier to retrieve if we need to change out the coloration, change the crown, something chips, breaks, if we need to clean out underneath it, what have you. But it can lead to a bulky cingulum. And I always warn patients when we're doing screw retained crowns, whether it's 6, 7, 8, 9, 10, 11, you can get a little bit of a bulkiness to the tongue. And really it only lasts the first 2 or 3 days. Their tongue goes a little crazy on it, but they get used to it, especially if it's well-polished porcelain zirconia. So let's just quickly go back through these. Just look at the angles. Obviously, the most buccal apex is a no-no. And as we go and swing, the most palatal of the apex is also not ideal. So really, it's this Goldilocks zone where our apex is kind of right, just palatal of the root tip, just palatal of the apex. So how do we get there? That's the difficult part. So when we talk about surgical technique to get that ideal prosthetic angulation in the anterior maxilla, it all begins with one thing and one thing only, and that is atraumatic extraction with no buccal plate damage. If we are too aggressive with buccal lingual movements and we break the buccal plate, or it comes out with part of the tooth, or we have some damage to it, we can get some pretty aggressive gingival recession or bony recession that's going to make an aesthetic implant very difficult, very challenging. So atraumatically extracting these teeth is an extremely important skill, something that comes with practice. There's lots of tools out there. There's the Acteon Cube or any other piezo that can help break those PDL ligaments. There are tools like periotomes, luxators. There's all sorts of tools like that. There are also just different techniques. Personally, I like the Ash forceps, the English forceps, if you will, and rotational force only on these conical roots. I don't do any buccal, lingual, bodily movement of teeth when I'm removing them, because the buccal plate is so sacred, and that's especially true in the anterior maxilla. As far as the surgical techniques, once the tooth is out, there's three main techniques that are around for people to get the ideal prosthetic positioning in the anterior immediate zone. There's a Lindemann burr, which is a side cutting drill. Comes with many implant kits. You can order it separately from several manufacturers. There's a freehand pilot drill placement, and we'll talk about how that's a little bit different than your typical pilot drill technique. And then what we're going to kind of focus on later in this webinar, which is the guided osteotomy preparation. So first, let's take a look at the Lindemann. The Lindemann, you can see here as it moves, it's a side cutting burr. It's used generally to bodily reangulate osteotomy. So if you're first pilot and you take your parallel pin x-ray, your PA, say number 19, and you realize I'm a little bit more mesial than I wish to be, the Lindemann is the perfect drill to come in and just drag bodily to your osteotomy, and then go back with your 2.0, 2.5, what have you, whatever your surgical protocol is. In the anterior maxilla, I like to place this near the depth of the socket, maybe just up a millimeter or two on the palatal slope, and I'm just bodily almost pushing the entire drill to the palate. So I'm not angling anything, I'm not rotating my wrist, it's just more of a push, and I'm going to make a slot in the palatal slope that will then facilitate me with my 2.0 drill, my 2.5, whatever. So look at this one more time. The way that the burr tip is near the apex of the socket, drags it directly palatal, and then we can go up a little bit. The Lindemann will cut on the tip if necessary. So the 2.0 drill, whatever your pilot drill, will be the next one, and just keep leaning on the palatal there. There's a technique also with the pilot drill. It's a little bit different than we might be used to, because we're not going to start where we want to end up. We're actually going to come in with an intentionally acute angle on the palatal slope. So there might even be, like in this diagram, midway down the palatal root slope. And after we break through and pierce the cribriform plate, that denser area around the tooth socket, we're going to immediately reangulate and drive it to the depth we want, straight down. Okay, so for instance, we'll see here, pierce the cribriform plate, reangulate, and go down. We're going to use the same technique for pretty much every drill in the sequence. So we're going to come back in the same technique. Now we have the 2.8 drill, pierce the same hole, reangulate, and drive to depth. These are all techniques to avoid getting stuck, getting pushed buccally with the apex of our drills and having that fenestration problem. One of my favorite techniques, because I'm a big guided digital dentistry fan, but I do understand you have to know how to do those first two techniques if you're going to be working the anterior maxilla. The guided osteotomy preparation is a little bit different. We don't have the option to reangulate or bodily drag guided drills, because the guide sleeve in the guide is going to hold our positioning. And that positioning is going to be equal to our final prosthetic positioning, where we decided we wanted the drill and the apex of the osteotomy to be in the first place. So our really only option is to use to only do this on class 1 sockets, like in the Gluckman study, which are very simple. We're just kind of staying at the apex of the socket itself. Or in this technique, we're going to use a brand new, very sharp guided pilot. And we're going to use a pecking motion, almost like half a millimeter at a time, because we don't want to go too hard, too fast, and allow our burr to deflect up that palatal cribriform plate. Every guide system, whether it's keyed or keyless, will have what's called wag, which is, if you can imagine sticking your hand through a a tube or a small ring, the fact that you can still move your hand, but your arm is still in the ring, that's WAG. So there is still the ability to move the apex of your drill through the guide sleeve. The tolerance is tight, but it's only tight all the way where the sleeve is, which is typically several millimeters coronal to the socket. So there's usually 17 to 25 millimeters of drill that is below the guide sleeve, and it can move quite a bit, enough that you might think, hey, this is coming straight out the guide sleeve, everything's going great, and you take your final cone beam and it's sticking out the buckle plate at the apex. So what I prefer to do, brand new sharp drill with a pecking osteotomy to make sure that we just get through that cribriform plate with the least bit of deflection possible. So in this slide, it kind of shows the peck, and then once you get through there, drive it to the distance, still pecking along the way every 2 to 3 millimeters. But the most important part is getting through that initial cribriform plate, that denser palatal slope of the socket. And you'll do this with every drill in the guided sequence. So this is the 2.0 by 17 by BioHorizons. You would then go to the 2.5 or the 2.8, or 3.2, and what have you, the same technique to avoid deflection if possible. So the rationale for guided surgery in general, not just for anterior immediates, but obviously it increases our accuracy. That's the whole point. That's why we want to do guided surgery, because we want to bring our plan to life. We want to plan something on a computer, whether it's CEREC, Sirona, Plan Mecca, your Blue Sky plan, Acteon. You want to be able to plan it on the computer and actually bring that into the patient's mouth. And a guide is the physical manifestation of your plan. So the guide will actually bring your plan into the real world. Obviously, we can help avoid some things we want to avoid, whether it's the sinus, the floor of the nose, maxillary undercuts, or posterior mandible undercuts, the nerve or the mental nerve, or any of those things. It will increase your speed, but that does not mean that we want to drill any faster. One of the first things that when I started doing guided, I would drill a little bit too fast, and I was actually heating up the bone because I was so excited that this thing was holding my hand. Oh my gosh, this is perfect. Let me go as fast as possible. And that wasn't really the point. The surgical speed is nice because there's less flap reflection perhaps, or there's less rechecking angles and double checking this and maybe taking more and more check films because we're doing a guided case. So it does make the surgery faster as far as time, but we have to be careful not to get a little bit too comfortable and use our drills too fast. There are now lower cost options in offices now, like 3D printing is a great example. That's what we utilize here. Some of the companies that have CAD/CAM mills can mill guides as well. So a lot of doctors and offices are bringing those in-house so that they can offer that to their patients, at less of a cost and at a quicker turnaround. Because right now, if you were to have a lab make a guide for you, it might take a couple weeks. And if you're sending it to, say, Sirona out in Germany, it might take several weeks. And it will cost quite a bit more money, hundreds of dollars. Nowadays you can get guides made for $40 to $100. Typically, the more expensive ones, if we're doing full arch stuff, the cost can certainly go up. But when you bring it in house, we can bring those costs down, and most importantly, we can bring the time turnaround way down, which is super important for doing anything immediate guided. The best part of guided surgery, the biggest rationale for it, is certainly that we are going to have more predictable restorations. You've already planned the restoration by the time you're doing the surgery. So if everything goes to plan, every visit from here on out will be much smoother. Whether now it means you can do screw retain crowns, which are certainly a lot easier and cleaner and cheaper than doing cement retained, and a little bit less likely to get that peri-implantitis we talked about. And if you're doing overdentures or something like that, we can make sure that we're paralleling the implants, so we're going to have less wear and tear on the O-rings and that sort of stuff. I'd be remiss if I didn't talk about limitations. There are certainly limitations. I've seen several myself. This is a picture of a case I did about 2 months ago here at the clinic. First things first, reduces the tactile sensation of your drills. One of the big things you learn if you're a big freehand placer is that you can feel the difference between D1, D2, D3, and D4 bone. But more than that, you could maybe feel hey, I just ran into something that's a little bit denser than the whole rest of this osteotomy has been. What could that be? Maybe that's the floor of the sinus, the floor of the nose. Maybe it's the lingual plate of the lower mandible, like in the case in the picture above. You can see the osteotomy in the number 20 area actually was so thin on the lingual, and I would have probably realized that, or certainly seen it if the guide wasn't in the way. By the time we took the guide off, I realized I had a strip perf the entire 10 millimeters of that osteotomy, which is a bad place to have lingual perforation. Thankfully, there was no complications besides the fact that we couldn't put an implant in there that day. But that's the kind of stuff that maybe we would have seen if we were doing this freehand. We maybe would have felt that extra resistance and thought to ourselves, what could that be? Let me double check. Whereas the tolerance of those guide sleeves can be a little misleading. A poor fitting guide can certainly cause more problems. This is a good example. The picture above that I just mentioned, the reason that the osteotomy was off is because I was utilizing the patient's 2 lower canines, which unbeknownst to me, by the time she came up with the surgery, were actually loose from periodontal disease. And instead of maybe making the smart play and deciding to go freehand instead, I thought, no, this is stable enough. And if you'll notice, the osteotomy in number 28 site is to buccal. So the entire guide had shifted counterclockwise. And so I had a lingual perforation number 20 and a buccal strip perforation in number 28. And you'll see I put 2 mini implants in between the osteotomy and the implants in the front to kind of try to make up for the fact that we couldn't place implants that day and get all 4 of the nice spread we wanted. Patients with limited opening, the common analogy of the 84-year-old grandma who can't really open her mouth or keep her mouth open. The general rule of thumb is if a patient can get to 30 millimeters from canine to canine, that they're probably going to be able to. That's probably enough space to get back in the molar region with an implant drill. The reason we measure canine to canine is it's a lot easier to measure canine to canine than molar to molar. So just an easy kind of number to keep in mind. Narrow spaces, lateral incisors, lower incisors, these guide sleeves can be quite a bit larger than your final implant, and then you're even larger than your drills, certainly. And so sometimes the sleeve width will not allow you to do something guided, and your option is to either do it freehand or maybe convert to a pilot only guide and then do the rest of the surgery freehand. If a patient's already edentulous and they're very flat ridges, very little vestibule, especially in the mandible where there's less landmarks, it can be very difficult to get a guide that feels nice and fit, nice and tight. Whereas in the maxilla, typically, if they have any sort of vaulted palate, it's a nice index that we can use as a guide. But guides are certainly limited in the mandible that is very flat and has less vestibule. There is an additional cost in time, whether you're sending it to a lab and paying a lab to do this and waiting a couple weeks to get the result, or if you're bringing it in-house, certainly there's a cost to buy 3D printers and the resin and all that kind of stuff too. And not to mention the training with your staff and yourself to know how to do all that. One of the most important things, surgical plans can certainly change. Anyone who's done a lot of surgery knows that sometimes you go in with the best intentions and we find out, oh, that infection was bigger, or oh my gosh, that buccal plate broke off when I removed number 11. I wasn't planning on that. Things can change mid-surgery. You have to know how to handle it. So the way we teach at Implant Pathway, most of our training is focused on freehand placement. We dabble in the guided stuff. We certainly talk about it and we introduce some of it into our live surgery stuff. But without having a good, solid background in freehand placement, guides cannot be a crutch. They are only an adjunct. And as long as you treat them that way, you'll be okay. Visibility is reduced. Another example, like 4 of these things are good things to look at this photo of my guide failure here. But visibility, if the guide wasn't in the way of me seeing this ridge, maybe I should have removed the guide in between certain drills and kind of seeing where I was going. In the case above, I had actually done the osteotomies prior to the alveoplasty. So I kept thinking, I know that looks a little lingual, but I'm sure once I alveo, the osteotomy will appear to drift more in the midline of the crest because it must widen. So that was a critical thinking error on my part too. I was a little bit too confident in what my guide was telling me. Irrigation impeded, because most of our drills are externally irrigated with the handpiece. That irrigation, that cooled saline, is not always getting through the guide because that tolerance is so tight, there's nowhere for it to go. So in my example, my first couple guided surgeries, I was getting a lot of crestal bone loss. I thought that's so strange. And it finally hit me that I was probably burning the bone quite a bit because I was not getting irrigation down there. I was also drilling way too fast and using the wrong technique, like I said earlier. But there are certain ways we can get around this. Certainly, if you have an internally irrigated drill system, which would be really nice, that's not an issue. Alternatively, you can cut slots in the apical buccal area of the guide. You could have your assistant having a monoject with some saline, adding a little bit of additional saline. And then we'll talk about the general guided technique as far as the pecking, the drills, almost like doing a root canal, as far as 3 millimeters in, almost pull it back out, recapitulate kind of thing. Let the irrigation get down into the socket and rinse some of that bone off and cool it down. So now we're getting to the heart of the matter here. So immediate guided surgery is a different bear on top of all those things, because now not only are we, hey, let's get a scan or a model to make you a guide. Typically these patients are coming in with teeth that they broke, or teeth that are about to break, or teeth that need to go, or a bridge that's failing. And we want everything to be perfectly placed, but at the same time, we have to take into account the time factor. And most patients, when they get to this point, are ready that day to get something done. So the rationale for immediate guided surgery, I always say, is when you need the placement to be perfect. Okay. When you want that screw retained crown on number 7, like this case here that we did at a pathway course, you need a guide to maybe hold your hand and make sure that's going to be restorable. If the patient can delay the surgery a couple of days, if they're not in a lot of pain, if there's not a large infection, if they're waiting around anyway for a flipper, they have a crown that has come off 7 times and it's finally time to do something about it, re-cement the crown, make your guide, make your flipper, whatever you're going to do, and you have time to get those 2 pieces and parts in order. I like to avoid losing your bearings. It's especially true in cases where we're fully edentulating a patient and we want to do guided placement for, say, an overdenture or a fixed full arch. Once all the teeth are gone, the gums are flapped, it can be really easy to lose your bearings and kind of remember, hey, where was my plan? How does it relate to what I'm now looking at, which is just a couple sockets and some bone? So guides can kind of bring us back to reality, bring us back to the final outcome and what the goal is in mind. I always say you got to have a plan B. Never guarantee to a patient we are definitely going to get an implant in today, or we're definitely going to immediately provisionalize any of that stuff. You have to have a plan B, which is often graft and return. If you're not getting that stability you wanted, if the buccal plate breaks, if the infection's bigger than you thought, always have a plan B. Placing non-guided can be a plan B. If my guide's not fitting, I'm going to put this aside and go back to one of those other techniques that I've learned. That can be a plan B as well. Anterior cases, upper premolars, lower premolars where we don't want to drill apical because the nerve's nearby. These are all great examples and reasons for immediate guided surgery. If you're going to do some parallel placement for future bridges or adjacent implants, you're extracting 7 and 10 and you want to place 7 and 10 and make sure they have enough drawl that you can make a custom abutment cemented bridge or a screw retained bridge. It's nice to have a guide to help adjunct that. And multiple implants after extraction. So tonight's case review that we're going to go over, it's a really nice older patient. His name's Ali. He came in near the end of the COVID kind of shutdown, if you will, with an emergency, clearly. This bridge was, he said, 20 years old. It was done in, I think, India or Pakistan, and it had finally broken, and he didn't even have it anymore. So at this point, he's in a little bit of discomfort, more so because his bite is a little bit off, and obviously an aesthetic emergency. So a failed bridge. It's a bridge from 9 to 12. I have an x-ray from the previous year when he was in the clinic, and everything was splinted together. It's probably the only reason it lasted even as long as it did. The adjacent teeth, number 8 and numbers 13 through 15, are actually implant crowns. So there's no ability for us to make a new bridge. And those implants, you'll see them in the x-ray here soon, are single piece implants. They're not minis, but they're single piece solid abutment implants. So it's not even something that we can later utilize, by removing the abutment and having custom abutments, and add some of our own implants. So we kind of have to focus just on 9 to 12 as its own little area, because the implants in 8 and 13 are not going to be part of our solution. Thankfully, in the x-ray, we'll see there's good bone apical and palatal to these roots. And one of the concerns was if we pull these and just try to graft or just suture, we're going to get some bone resorption, maybe some gum resorption, and we'll never have the chance to place the implants at the same level as 8-13. And we might have an aesthetic compromise when we get to our final restoration. I call this the simple equation for guided surgery. If you're not super into doing your own guides, this is kind of a cheat sheet. Essentially, the two things you must have are a cone beam and an STL. An STL is simply a soft tissue model. It's a digital model. There's a couple ways to get it. You could use any of the multitude of intraoral scanners out there, CEREC, Planmeca, iMedit, Heron. There's so many now, it's hard to even keep track. And then obviously a cone beam, and then you need to merge those two in a software. What we use here at New Horizon Surgical Center is the Acteon software. Their guided software is built into their cone beam reading software, which is really nice. So we don't have to use a third party. We don't have to export and import a bunch of things. So you need some planning software to bring those two things together, because the soft tissue model of the mouth is most important for guides, because the cone beam is only going to show you hard tissue. So certainly you can plan implants in a cone beam and you can say, here's the proper spacing, here's what I'm thinking. But in order to bring that to the mouth, we need the soft tissue model. We need something that's more accurate for the actual condition of the mouth itself. By combining those two in the software, we can export our surgical guide. And then there are several ways to bring that surgical guide file to life, whether it's 3D printing, CAD/CAM milling, or exporting to a lab to have them do one of those two options. So we're going to switch over here to the Acteon software, which is their AIS 3D 5.0. And so here I'll try to go as slow as possible. I know that Zoom kind of makes it rickety when I start moving things around too fast. I've already gone ahead and subtracted his mandible from this scan just so it's a little bit easier for us to see. But you can see quite a bit of scatter on this scan, as you'd expect from a lot of implants in PFM, crown, and bridge. This scan was actually taken, like I said, about 6 months to a year prior to his aesthetic emergency. So it still has his teeth. And then what I have here is the STL, or the soft tissue model of the mouth. And I've gone ahead and ditched out the little root pieces. And I did that digitally. And the reason is, when you see that we're going to make a guide, we know that the guide's not going to go in his mouth until the teeth are gone. So I can give myself a little bit of leeway, a little bit of play on the model to build my guide to. So the way that Acteon works, and most softwares work when it comes to making a guide, there's a couple ways to what we call stitch or align these two together. The most typical is to do what's called fit points. So if I click on the cone beam, you'll see a little number 1 just popped up on the mesioincisal edge of 8. And I can come over here and I can click it in the same spot. And I can do this for several spots. I'll usually aim for 6 spots or so. And I try to spread them out throughout the mouth. It gets a little bit harder when there's a lot of metal and scatter, and I can't use crowns 9 through 12 because they're not in my model here. Another nice thing that Acteon and a lot of new softwares have is this assisted algorithm. So if I just click assisted here, it's going to start doing the thinking for me. It's going to try to find enough overlapping spots between the 3D rendering and the STL model that I've imported, and it's going to stitch it automatically. So this works 95% of the time on this software. The algorithms are only going to get better, which is nice. But if you have to, you can always go back to the fitting points option. So here it's gone ahead and stitched, and you can see our kind of pinkish model. It looks pretty well overlaid with the cone beam. What we need to do is we need to check in the different slices. So here's our axial slice. I'm going to come down. I'm going to come down. And what I'm looking for is that outline, that kind of peach outline should mimic where we see the crowns and bridge. And what I typically do is I'll come right down to where the incisal edge first pops into my axial slice. And I want to see that that's the same time that my outline pops in. And see how right here where number 7 and 8 are, right when it pops in, so does my outline of my stitched STL. So we can check one more time from the coronal slice. As we come forward, you see over here the buccal lingual of these crowns are nice and stitched. So we come forward again. Good. So if I'm happy with the stitch, I'll hit apply. And now you'll also see that I'm going to delete the cone beam data here. I still have the model of that day that has his roots. So I'm not going to lose the orientation. So I can look at that while I'm planning it, but I'm going to build the guide on this one that doesn't have the roots, because it's going to be a more accurate representation of what his tissue will look like when I put the guide on, okay? So we're going to go down to implant planning. And here we can get a first look at his cone beam. So here's one of those single piece implants, just a solid chunk of titanium, no internal bits, nothing we can unscrew. And it's the same here with number 8 and number 13. That's a huge one. And number 15, these big implants. So there's going to be I can't use these as part of my prosthetic. So here when we come to number 9, our first site that we're going to plan, I'm going to zoom in on this. This is probably between a class 1 and a class 2 root socket morphology. Okay, lots of bone, apical and palatal, really, really short roots, which is actually going to make this a perfect case for an immediate guide. On the software, I'm going to say, hey, let's add an implant number 9. And these are the BioHorizons Tapered Pro implants. I have the full library here to choose from. And so for this one, I'm going to do a 4.2 by 12 and see how that looks. Okay. So 4.2 by 12, you can see because we have a cone beam before his teeth fell out, this angle is coming just palatal to the incisal edge. So I like that angle. I'm also going to keep it just a slightly below buccal plate. And one thing to keep in mind with cone beams, there's almost always more bone than it looks like. So the buccal plate may appear to end right here in a nice, distinct cut, but almost certainly the buccal plate comes a little bit further up. So if we place it kind of even with this buccal plate, we'll probably be that 1 to 2 millimeters sub buccal plate, okay? So I'm gonna go ahead and hit apply for that first one. Oh, let me actually go back because I forgot to add my guide sleeve. On the right side here, because their guided software is embedded in their viewing software, I can go to the BioHorizons guided sleeves, pick my correct sleeve, which in this case is a 4.6 by 12. It's going to yell at me because my sleeve is just hitting my STL, but that's okay. It won't be a problem. So there's going to be my guide sleeve. We're going to scoot over to number 11. Number 11, a little bigger tooth. We're going to use a bigger implant. We'll go up to a 4.6 by 15. Let's see how big that is. That's a big boy. Same thing, leaning back into that apical palatal bone, avoiding this buccal undercut. Buccal plate's right about here. Probably bring this out just a little bit more, and we'll pick our correct sleeve. And then our last one is going to be number 12. We're not going to place an implant at number 10. It's unnecessary to make soft tissue very, very hard to control. We'll do the same size here, a 4.6 by 15 for 12. Look at all this bone and this tiny little root. So let's just make sure this is coming out the central groove. For this to be a single crown. Now they're red because they're upset how close they are in the software. So I can separate these. There's these little safety zones, these little boxes around it. So there, now it's nice and green. Okay. Oh, I forgot to put the guide sleeve on that one. Let's go back real quick. Okay. So from here, I've just kind of lightly put them in the software. I'm just getting my preliminary placement, and I can take a look and see if I like where these are coming out. Now, maybe I think number 9 is a little bit too palatal. I can come back, I can change it in any view. I can grab the coronal and swing it out, grab the apex and swing that back. And one thing that's really nice is, like, let's say I like the angle of number 9 a lot. I can right click on number 11, set the axis parallel to 9. Because I think I want to put a bridge between 9 and 11. And we'll do a single crown on 12. That might be a little bit overdoing it. Let me switch the angle of 11 back to where it was. Maybe let's make 9 parallel to 11. Okay, that might be a little bit more reasonable. But you get the idea. We're not going to sit here all night and get this perfect, but trust me, I did the day we were planning the surgery. But this whole thing will probably take about 10 minutes. Get these angles nice and perfect. So for the sake of what we're learning about tonight, I'm going to go ahead and kind of put these generally in a correct spot. Get these pretty close. Okay, and then number 12 could be just a little bit more. There we go. Okay, So we have our implants planned, we have our guide sleeve chosen. We're going to go down here to guide design. And what it's going to ask first, it's going to say, okay, here's your model you're using, Steve. What angle are you going to put this guide in the mouth? Because we're going to make an undercut. Everything brown here is currently an undercut to what they have it set to. So I like to generally parallel the placement so I can see all my guide sleeves. So let's say from here, there's a little button here, set insert direction from view. It's going to make me a new undercut model, and it's going to block out all these undercuts. So we're going to generate an undercut model. It's just going to block that out so that when I create this guide, I'm not going to have any undercuts to deal with. We'll hit next step. And now it's just going to want me to draw the outline of my guide. So generally, I'll use as much as I can as far as the teeth. We're essentially going to be making a little suck down night guard here. So I've got my connected guide. I'm going to hit create guided. It's going to make what's essentially, like I said, a suck down night guard over the top. And you can see where the sleeves are going to be. Okay, at this point, if we wanted to, we could smooth some stuff. We could bring this back. We can add, remove. We can add windows. A window would be nice to confirm it's fully seated. I'll be able to see those incisal edges. And we can even add text. So I can put the patient's name on here, the implant size, the date of the surgery, what have you. So the next step, it's going to cut out the holes that are hiding my guide sleeves here. And we're back to this screen. So now, if I go to object list, I can kind of get rid of this view, and we can see here's my guide. So this is the digital file for my guide. Fit the intaglio is going to fit the soft tissue model I gave it and the teeth. There's a little window, which I didn't actually do the day of the surgery, and we've got our guide sleeves. So the next thing we're going to do, we're going to export the guide. So I'll just come up here, export. There's no export fee for Acteon software, and we're going to export that into Rayware. So Rayware is the software component of a SprintRay 3D printer. So here's the guide that I had made that day. You see there's just no window, otherwise the same, and I've made little supports. So I'm going to go ahead and send this to the printer. It's saying, okay, we're going to use surgical grade resin, 100 micrometers. It's going to take 6 milliliters, which will probably cost me $3, and it's going to take 49 minutes. The post-processing for this will probably another half hour to cure it and clean it and put the sleeves in, but I can have this guide ready to go in 2 hours or less. Okay? So that's the process of going through the software, making the guide, kicking it over to your 3D printing software, and having it printed. So here's our plan once again. Implant bridge from 9 to 11, single crown on 12. We're going to use BioHorizons implants, 4.2 by 12 in the front and 4.6 by 15s in 11 and number 12. And we're going to place this fully guided, which means everything's going through the guide, including the implant. If you do a guided surgery, you might only do the drills, take the guide off, and place the implant with a freehand driver like you might in a freehand placement. But for fully guided, that means we're putting everything through the guide, including the implant. And that's going to help us keep our vertical apical coronal level correct. So flap design, because the implant on number 8, we did not take our flap all the way up into the sulcus, if you will, of the implant. Same for number 13, we kind of couldn't avoid it, but we went around it just a little bit to the distal buccal. And all these teeth roots kind of rolled out with that periosteal elevator. Dr. Christine Kieber did the surgery here. This was back, I believe, in May of 2020. Degranulated all the sockets, including number 12, had just a little bit of stuff in it. So we degranulated all that, got that out. Guide was tried in, well fitting. Since we don't have windows, we simply took a mirror to the back of the mouth, checked to see that everything was tight on the posterior aspects of the guide. There was no rocking, so on and so forth. The BioHorizons guided kit is a keyed kit. It has these spoons that will change the diameter of the sleeve down into the diameter of the drill you're currently using. So here, the 2.0 drill, you can see it written on the key here, 2.0, is used to get our initial pilots. I took the guide off to get this fancy photo just to show that we have the parallel pins. Typically, this would be skipped if we're doing it fully guided and just kind of going through the surgery. But it's nice to show that 9 and 11 are nice and parallel for a future bridge. You can see in the final plan, this was placed quite a bit more buccally as far as where the access was coming out. I know that in the software run through, we just did they were still sticking out a little bit towards the palate. And number 12, just a simple single crown. The guided technique, and I'll turn the sound off because it's pretty horrible. That pecking technique, these are the 3-2 or 3-7 drills, but see how we're going down 3 to 5 millimeters, coming out, letting that irrigation get all the way down onto that drill surface into the osteotomy, cooling things down. We're not just taking it and hubbing it straight to the bottom. That is how you burn bone and get into trouble. So here's the 4-2 drill, the final drill for number 12. You can see same thing, nice and easy up and down placement. That doesn't look as fast, but that is running at least 1200 RPM, if not more. And we're just letting that irrigation really get down there without taking the entire drill. Look how long this drill is, though. And that's why WAG becomes an issue if you're not doing that pecking motion. So the implants are placed fully guided. So like I said earlier, fully guided means through the guide, the implants went in. So in the BioHorizons kit, there's this guided carrier that has 4 slots. They're different vertical stops based on how the guide was designed. And this little guided fork goes into the appropriate slot based on your guide design and stops you and gets the correct apical coronal dimension as far as where that implant is being placed. So here we can see it's fully guided going through the carrier and through the guide. And then I always take this photo. I call this the money shot. If you don't take this photo on a guide surgery, did you really do a guided surgery? Probably not. This is just showing that the implant platforms are all seen through the guide, nice and placed right where we want them. So we take Ostel readings here at the clinic. You can also take Penguin, ISQ. The numbers are slightly different, but as a rule, anything above 70, like this graphic on the left says, is good for a single stage immediately loading. Anything 65 to 69, if you're splinting, you can immediately load it. Certainly you can do healing developments. We start getting into the low 60s and below 60s, and we're talking about burying something, cover screw, a membrane over the top, perhaps. His Ostel readings were the highest I've ever seen in a maxilla. To this day, I've never seen anything in the 90s like that before. He had concrete for bone. Because he had lost the bridge and this was done as an emergency, we didn't have any sort of preparation to give an immediately loaded splinted temp, but we certainly could have in this case with those readings. We used BioHorizons biologic pericardium membrane. I like pericardium in a case like this because I'm not going to get 100% primary passive closure because we did pull some teeth, and we're not going to destroy his vestibule and get rid of all the KG by releasing and pulling it down. And pericardium tends to last a little bit longer in my personal experience than a simple collagen. But it's also resorbable, so it's not PTFE. We don't have to go back in and tug it out. So it's going to last us the couple 5 days to 2 weeks that we need it to get that to close over the top. So I like to tuck the membrane in first prior to placing the graft material. I just find it easier because tucking a membrane in after graft can be frustrating. If you're familiar with membranes, that's sometimes one of the most frustrating parts of surgery is trying to get the membrane to lay where you want it to. We grafted each socket, number 10 socket, and the gaps between the buccal plates and the implants with Mineros 50/50 cortical cancellous. So the cover screws were placed prior to this. The membrane was then tucked into the palatal flap over the graft, and we placed, and we did a very simple figure X horizontal mattress to help approximate the flap a little bit and give a little bit of tension relief, and the X over the top, just kind of another safety gate to keep the membrane where it is while we do our continuous suture. So PTFE is one of my favorite suture materials. I know it's a little bit more expensive. I just love the way it ties and handles, and the tissue response is second to none. It's almost as if nothing's there, which can be kind of a pain in the butt when you have to cut it out 2 to 4 weeks later because sometimes it's so uninflamed, it's hard to even find. Patients don't appreciate that always, but I do love the handling it does that day. And so you can see here we do have some secondary intention healing sites here. So that pericardium is going to give us the time we need for that to granulate over. So we left these sutures in for 2 weeks and saw him at follow-up. So here's the final case intraorally in the mouth. And then here's our post-op cone beam. So you can see here number 9, the 4/2x12, number 11, number 12. So a lot of you are probably looking at number 9 going, the heck? Wait a minute. Didn't we plan this to be back in this part of the bone? And I'll say this, I like this picture of the Um, when you see a patient with a lot of metal in their mouth, we're going to have a lot of issues with beam hardening. It's true with even just around single implants, let alone of a patient that has as many implants and PFMs as he does. I love taking photos of the surgery because when I see an x-ray like this, I just go back to my pictures. I say, wait a second, if it was that buccal, I'd have seen it the whole time we were doing this osteotomy. And you can see here, the initial buccal plate was nice and thick buccal plate. And then here's our placement, with the pericardium tucked in, but we can see we're nice and palatal to it like we had planned to be. And so here with my orange line, I'm actually drawing what I think is where the actual buccal plate is. You can see a hint of it here. Yeah, we're a little bit close at the apex to where the constriction is, but this shouldn't give us any problems at all. So beam hardening is a real thing, especially in post-op cone beams when we're looking at 12 implants we just placed. So I like to do this. This is the planned kind of 3D rendering when I was doing it on my computer. And then here's the post-op cone beam 3D rendering. All we're doing is sliding the 3D rendering, tolerance or transparency down to get rid of all the soft tissue and other stuff and just seeing the metal. So we can see just how closely these are. This patient has enough implants to do a traditional like all on 7. Unfortunately, these other 4 implants are all those single piece, solid abutment types. So that's not an option. Okay, that's it for that case. If you feel like it's over too soon, I know it's been 55 minutes and you want more, I am probably most active on Instagram at VorholtDDS. I share a lot of what I do in what I consider to be one of the most interesting jobs in implant dentistry, which is doing the follow-up and screenings for 5,000 implants a year down here at Tempe at the New Horizons Surgical Center. So I do like to share a lot of stuff, whether it's screenings I had that day, follow-ups, the good, the bad, the ugly, complications and how I deal with them, sometimes surgical walkthroughs and behind the scenes, that kind of stuff. So here's just a couple clips of things that you can expect to see on my Instagram, not for people who are a little queasy. I'm sure none of you are if you're already here for this webinar, but maybe don't look at my Instagram when you're with family and friends at Thanksgiving, okay? All right, thank you so much, everybody. This is all my contact information here. You can email me, my cell phone's on there as well. If you're interested in live training with us, by all means, implantpathway.com. And then if you're interested about me and personally how I got to where I am, I do have a personal website that does go into some of that. Thank you so much. Okay, looking at the Q&As here, we have a couple questions here about the implants we placed. Let's see. A question here, if we loaded those implants, I think that was probably asked maybe right when I showed the ISQs. We did not load those immediately. Like I said, we weren't prepared to have ISQs that high. And as an emergency patient during the shutdown, it was not something we were prepared to do. However, the patient is now currently in the PMMA temp. I was unfortunately unable to get photos because he was just in last week and we didn't get pictures of it, but we have now put him in a PMMA temp and he's getting new crowns on all of those implants as well so that we can get his VDO back to where it needs to be. So he's currently in like a very interesting roundhouse PMMA temp. I ended up placing implants in sites 3 and 5 about a month after this surgery. So the PMMA temp is in 3, 5, 9, 11, 12, and kind of rests over those strange abutment implants that he has in there now. But yeah. Hope everyone enjoyed the webinar. Thanks so much for coming and have a great rest of your evening. Thank you so much.